Good morning, everyone. Welcome to week 15, November 28 to December 4. And for this unit's contents are the following: care of clients with neurologic and special sensus emergencies, care of clients with GI emergencies, and care of clients with GU emergencies. For Unit 6, these are your activities. You only have 3 activities for this week. This is to watch your Unit 6 lecture, which is recorded. We don't have live as of now. Unit 6 additional resources. Click on those resources and please watch those videos. These are the videos that I mentioned in my lectures but didn't discuss in thorough. And Unit 6 knowledge checks. So we'll start our discussion with care of clients with neurologic and special sensus emergencies. Code blue and unconscious patients. So for the unconscious patient part, I'm gonna give you a link to watch the care of a patient who are unconscious, and then I'll move forward to discuss code blue. So code blue is when you call code blue when your patient stops breathing or unconscious and loses their heartbeat and the patient is full code. So you then press the code blue button, and then it will trigger a notification to everyone who is part of the code blue to come and see a patient. Okay, so to call code blue, you have to press the code blue button found in the wall or delegated numbers to call. For example, in the institution where I work, we call 555 and an operator will answer you and will ask you questions about the whereabouts of your call. Next is you may also call code blue in the event you deem it would benefit your patient regardless of them not coding. So bisag nagkuan ka nang nagduda ka na unsa ni pasyente himat yun or dili unsa kung baton, just call code blue, but not all the time though. You need to do a very quick assessment kaya sinatugan imong pasyente, no? Now this is the video that I wanted to share to all of you. This is the care of a patient who is unconscious, discussed by a doctor here. So please watch this video. The link is found in your additional resources. And this is also the video on Glasgow Coma Scale. So when you work in the emergency department, you need to know how to do Glasgow Coma Scale or the GCS scale. Please do watch this video, and the link is found in your additional resources. So this picture is from page M at THP where I work. So we put this behind our badge, so you will see that there are a lot of codes, and if you are tasked to call code blue like over the phone and dial 5555 in our workplace, you have to tell the operator the whereabouts of your call. Now this is a what do you call this, the critical care response team criteria. This is the calling criteria. Okay, so before calling code blue, so makita man yung pasyente nga murag nakuha na siya o murag ni down na iyang health ba, you consider this rapid assessment of critical events, a calling RACE team. We call it RACE. It's available in Canada and especially in Quebec and in Ontario. I don't know if what we call what's the name of this one in the Philippines. I'm not sure. So this is the first thing that we call before we call code blue. So this is in front of you, is a slide showing the criteria. So first, is there acute change? When you see acute sudden, okay, acute change in airway. So you have to take a look at if the patient is like if the physiology of the patient is threatened. Stridor, there's stridor, and is there excessive secretions? Okay, baka na mo kay ano makita yung pasyente mara siya goldfish nga himatkin, may kita man na goldfish kuha din sa aquarium, gibutan mo sa lamisa, kita ni mo nagkuan kasi nana henti. Next is breathing. So take a look if the patient's respiratory rate is less than 8 or greater than 30. Okay, himatyo na less than 8. Kung pa himati na paspas kayo nag-grasping greater than 30 so imong ipon. So you need to count 1 full minute for this kind of patient. Next one is distressed breathing, no? Kung nang kuan na ba nang siya respiratory distress, no siya ginhawa, something is obstructing in ana. Saturations less than 90, pulse oxygen less than 90 on 50% oxygen or 6 liters per minute. So, pasyente nimo, kita nimo ang lisod ginhawa, pasyente, lisod ginhawa, despite na siya nasal prong. Please be mindful of the rules and regulations in your country. In Canada, nurses makabutang raming oxygen. So, panitan maglisod ng pasyente, tangan nila mo og 2 liters prong, 1 to 2 for comfort. Panalitan, despite sa nasal prong oxygen sa nose, despite ana ang pasyente kuan gihapon maglisod gyapon ginhawa, butangan na mo non-rebreather mask, butang na mo siya sa 50% nya 6 liters per minute nya. Kung panalitan wala jud mahitabo ana, less gihapon ang saturation by 90, supposedly mo increase na siya to 90, 92, 94. So amo ang satisfied nami nga okay na saturation kung maabot na siya og 94. Unya kung less than 90 gihapon, unya systolic blood pressure kay low or high, unya kanang ang circulation sa pasyente kay ang systolic blood pressure kay less than 990, unya ang or greater than 200, unya human kay or decreased greater than 40 millimeters per mercury, and heart rate is less than 40 or greater than 130, tawag na mi ana sa race, no? Yeah. Another is neurology, so decreased level of consciousness. Ang pasyente nimo, dili na kayo mo reply nimo, no? Magkuha na siya, di na mata, di na magamit imong GCS. Imo na din tanawon ng GCS, ana. Unsa nga GCS, tanawon ninyo ang video, please take a look at the video, kaya makita ninyo unsa nga GCS are reportable. GCS 8, 6, and ana. Other is the urine output is less than 100. Normal urine output per hour is 30, right? And serious concern about the patient and needs medical assistance. Sa moang trabuan kay motawag kag 7223, I don't know sa uban nga institution silang gamit, basta na siya dedicated call line for that. So motawag din ka nga. So ang imuhang the way ka mo report is that mingon ka nga, hi, this is Domino from, for example, from the emergency department. I have a patient here. I see that the patient's blood pressure, vital signs, blah 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 is down. The patient is distressed, and despite oxygen of non-rebreather mask at this and that, or venti mask at 50%, the saturation is less than 90, and the patient, the level of consciousness of the patient has decreased like acutely. Can you please come and see this patient? Mabuti na sila. No? So these people are made up of nurses from the ICU o kung ano sila, RT. So mabuti sila ilang tanaw na pasyente. Yung madali nila ilahang tabangon ng pasyente. So this is we call this a soft code do sila ang madto. Pananglitan gani naabot ka sa imong area, pasyente ko kanang gid siya, down na gid siya, unconscious na, white pulse. So tiyatong on how to deal with that one. So tawag ni kag code blue. No, diyan sa takot to ha. Okay. So this is a code blue button, no? So code blue buttons are located in the patient's room, which are similar to this one, the one that you're looking at. So in ana ang noun sa code blue. Okay? So asa ana kaning nay nakabutang nga code, no? Kaning nay nakabutang nga code kani siya. This one here. Okay? Kana mo na code blue. So now, inyong pasyente, inyo siyang i-orient nga this is the code blue button. Ayaw ni pinduta. Okay? So kano saan niya gamiton? Kano saan niya gamiton? Kaning staff assist. Gamiton lang nimo siya kung imong pasyente. This will alert everyone in the unit. Only in the unit. Kung code blue, in the entire hospital. Sa kaning staff assist, only in the unit. So, kana siya kung may mahog, inana. Kung kanipod, kaning imuhang kuan diri plug, kan siya connected to the call bell. So, call bell kanang wire siya na siya red button para sa pasyente to call you. Yang nang i-press aron matawag ang nurse. So, call bell. Nurse call bell. Kani siya, ining na X is to cancel the staff assist call and the patient call. But you cannot cancel the code. So, once the code blue is pressed, hinanan ka mo tawag ana sa dedicated extension line. Tawag nimo to clarify that the code blue was called in error. So knowledge transfer number 1. Where can you find code blue buttons? 1A, they are found in the patient's room. B, they are only found in ER. C, they can only be found in the charge nurse's office. And D, they are portable, so each nurse carries them. So who will respond to your code blue? These are the following team that will respond: respiratory therapist, ICU, primary physician, porter and security, patient care coordinators. Kaning mga patient care coordinators, sila ni ang mga kanang mutanaw o rooms sa unit kung napabay available rooms, sila nilang matawag sa charge nurse nga na ay room dito sa unit, sila man arrange sa kuan kanang mga ngayon nga buhaton sa like managers, clinical educators. So clinical educators, I don't know kung nabataan sa Pilipinas. Ang clinical educator, for example, na kasi nagtrabaho sa emergency department, so ang inyong emergency department na siya kagaling ng clinical educator. For example, ang nurse na siya gaps in education or first time niya perform a procedure, ihatawgon ang clinical coordinator to a clinical educator to teach the nurse how to do the procedure properly. So mo siya resource sa information. Dili na kami still mga tanong sa imong kauban nga nurse, kay sometimes ang itudlo sa imong kauban nga nurse, especially senior ones, kaya kato sila ang hibawaan sa una, dili ang most current. So kanip ang clinical educator, sila ni ang mo keep current on all nursing education. Muna na kanindot ani niya. Kung clinical coordinator ka, kinahanglan intelligent ka, di ba? ER nurses will respond. I think 2 ER nurses will respond. Airway team. So during COVID, namin gitawag airway team. So muna ang mga team nga mo intubate sa pasyente. Safety officers. What's the safety officers? This is the secret why nga wala kay mo katag ang COVID during code blue. Why? This safety officer is a nurse or someone trained in PPA, trained in COVID, na siya knowledge about epidemiology. Siya ang mutanaw sa mga tao if they properly wear the PPE, if the protocols are followed. Unya, tanawon siya ang musaway nga, oh, wala ka nito follow out ka. Yan, siya ang control sa number of people inside the room sa asa na code blue. Nurse's role. So inside the room, there should be first and the second responders. The first nurse should be the primary nurse. Kaya ikaw man ang unang nakita mo ng first nurse, and then a second responder. Code team, maabot ang code team, ako nang gisutan. Up to 3 nurses, including the documentation nurse, will get inside the room, and 1 registered respiratory therapist will come inside. Outside the room, 1 RN or RPN. So in Canada, we have registered nurses and we have registered practical nurses. So both of them in PPE attire to assist the team in obtaining supplies and samples. Nasa gawas na huwat. Okay, 1 code safety officer. Mali ang gingon niya katong safety officer. So this one minimizes the number of staff in the room. Siya ang liaison officer sa inside the room. Na pila ka tao ra na dito, make sure nga ang kaning nasa inside the room orasan ang mga tao na, and ensure proper donning and doffing of PPE. Stick to kay ni sila. Tabang pod ni sila. Di sila para sa una ba nga kuan ang supervisor kay mangitag sayop. Kini siya di siya mangitag sayop. Mo supplement ni siya sa education required. 1 registered respiratory therapist RRT who will assist the patient in obtaining necessary supplies and equipment. So even though resuscitation has to be done immediately, healthcare provider safety remains the critical priority. Healthcare provider needs to don the appropriate PPE when participating in resuscitation. So dili ta mo ra si Darna no, ditso laghamag no. Don't rush. Don't rush. So in times sa COVID kay dili mo ditso rush no. Dili ta heroes, mga matay pud ta. So our safety remains the critical priority. So hinalang ka mag-PP before ka mo assist in code blue, before ka mo resuscitate sa imong pasyente. So PPE required during code, standard risk patient mao na ang required. That's na in front of you. Fitted test N95 respirator, full face shield, N95 respirator during COVID kay mo recycle me. So i-drop na mo sa kanang paper bag, nila process for recycling. But karon kay disposable na, one time use only. Full face shield, level 2 gown or higher, and gloves. Heightened risk patients kanang mga pasyente nga na COVID kay kay N95, face shield, head covering, level 3 gowns or higher. Level 3 gowns are the gowns that are repellent sa water. No? Yellow ang color ana. I don't know sa Philippines, for sure nataan na sa Philippines. Gloves as well. So this is the process of code blue. So the one that will trigger a code blue is when you found out that a patient is unresponsive or inactive with cardiopulmonary arrest. And then the unit level will respond. In the unit level, so sa area kung sa asagi tawag ang code blue, mo respond sila. So responder 1, ikaw nga nakita, you're the responder 1. So activate code blue response and call for help. Tawagin mong i-code blue. So sa gawas sa room na lights, ang lights musiga na siya, indicating that the code blue is done. Pwede sa kang siya nga help din, imo sang i-activate. Dili mo siya help niya, wala nimong i-activate. Okay, that will be a cause of delay. Pwede mo matin 15 seconds. So activate, press, or call 555, or go on. Kanang tawag ana, kanang yell. Me, I press and yell at the same time. Responder 1 initiate CPR in the current PPE that is worn in the room. No, kung pagkita nimo mo ang PPE gisulod mo nimo gamiton. And then a safety officer will come around, attend the code, and responder 2. So, sir, unsa man ni kanang nana din ni role play sa kuan sa imong unit? Yeah, at the beginning of the shift, mag-assign na mo ikaw responder 1 in case na code blue. Not responder 1 is always nga itong nakita. Ikaw responder 2, ikaw ang safety officer karon ana mag-assign na sila. Responder 2, do not rush inside. No, sometimes kung makita tag code blue dagan din ambak din sa kat3. CPR dayon, no. So pasagdan sa nimo ang responder 1 nga mag-CPR, ikaw ang nasa gawas maadto ka sa imong safety officer. So the safety officer will instruct you to wear your gloves, take a look yun sa inyong pag-wear og sakto ba. And then retrieve code blue card and step 2 to be used for chest compressions. And then responder 2 will enter the room with step 2, itang tungtunganan, code blue card, and apply non-rebreather to the patient and take over the compression. So imong inon ang responder 1 nga gawas na kay ako nimo overtake mo kuan. Next is responder 1 leave room done appropriately, PPE, and re-enter the room to assist. So healthcare provider must scan the area before beginning manual ventilation to ensure that all healthcare providers are wearing appropriate PPE. And then code blue response team arrival. Mo na siya, no? Arrive na ang code blue response team. Okay? Okay. And then they perform huddle to determine the plan of care and roles and responsibilities. Paspas ka na sila mag-huddle, seconds na sa gawas. And then they enter room individually with equipment needed to support your role in the resuscitation. So even if na sila sa sul, manood na sila, magkuha na sila, magkuha na ng plan. So I've attended several code blues in my life as a nurse. So daghan na kay kog nakitaan niya, indot kay na siya kay team effort na siya ang code blue. Dili na siya effort sa doktor, no, dili superhero ang doktor nga magkayab-kayab ang iyang kapay, maadto din siya sa kwarto kay iyang i-save ang life sa patient. Kani kay code blue is a team effort. Sometimes the doctor will ask you kung nabamoy lain nga idea on how to manage the patient. Mao na nakanindot ana niya. And then if the patient was resuscitated, masulti ng doktor, na resuscitate nato, stop na nato ang CPR. So let's call ICU. So after a patient is resuscitated, automatic gina ICU gid na siya. Wala laing adtuan ang pasyente, ICU gid na siya. So if you're the charge nurse, you call the ICU charge nurse and arrange the transport of the patient ASAP. So sometimes magdala na sila telepono na sila sa gawas nagkuha, magdala na sa telepono, nag-communicate na sila to prepare a bed kina may pasyente nga gi-code blue. So code team RN and RT keeps face mask, shield, and head and neck covering and dons new gloves and gown and prepare for transportation. RN and RT transfer patient with porter and dedicated security guard to manage route, indoors, and elevators. No, walay delay. Okay. Yung naikuyog ng RN o PT. happy na time nga padala ang ga-code ng pasyente without a nurse ang naadto kay porter o yan nag-cardiac arrest ng pasyente on the way. Unsa na lang, no? Next one is stroke. So stroke is the sudden onset of neurologic dysfunction caused by a disruption of blood flow and that lasts for more than 24 hours. This is the 5th leading cause of death in the US, and 8 million people have stroke, and 130,000 people die from stroke annually, and 13% is hemorrhagic stroke, and 80% of the stroke is ischemic stroke. So asa man di ay ang kuan, ang 7% could be other. Okay. Now, stroke is a disruption of the blood flow that deprives tissues of oxygen, leading to cellular ischemia and death. Okay. This is a person like a person who has a stroke, no? We call it brain accident or cerebrovascular accident. So na siya headache, mental changes, na siya confusion, okay, na siya disorientation, na siya memory impairment. So I don't know how you practice your nursing, but when we go to our patient, my vital signs mosulti din sa pasyente mo, hi, good morning, my name is Domino, I'm your nurse. Kung first ni mong encounter sa pasyente, no? I'm your nurse for today, I'm gonna check your vital signs. Ako, mosulti ko mingong vital signs, kaya mosulti ma-intimidate sa vital signs, mingong dito nga, I'm gonna check your blood pressure. Can you tell me, for the purposes of orientation, can you tell me your first name and last name? Ano yun ko? Di pasyente nga, mo ni ang pangan, mo ni. Can you tell me where you are right now? Can you tell me the date for today? Can you tell me why you are here? So kanang pangutana ha, upat ka bukang pangutana, meaning alert oriented times 4. Kanang upat ka pangutana, you have to ask that because a patient with stroke is confused and disoriented. Shikibaw kinsa siya, shikibaw ngano na kay disrupted naman to ang parts of brain that functions with memory. So mo na hitabo. So na memory impairment yung pasyente. One time I have a patient niya, akong ibautan na, can you tell me your first name and last name? Very start of the shift, night shift ko ato, very start. You tell me your first name and last name. Pasyente, hey, you're so silly. Kanang kuan ko no, you know who I am? I don't know who you are. Ang ginang pasyente. So, ang hitabo na stroke. Suka after na stroke. Yung na din, proceed na kasi mo ang interventions for stroke. Patient with stroke might have aphasia, no? CVA, left hemisphere. Might have respiratory problems, neuromuscular control, no? Di kay sa silang kamot, di ka kumot sa imong palms, no? May have a decreased cough and swallowing reflex, no? So di sila ka ubo, no? Di sila ka swallow. Might have agnosia or decreased sensory interpretation, incontinence, no? Kaihi na sila, di sila makaihi, hindi makaihi. Seizures, no? Patient with stroke might have seizures, and then hemapheresis or hemiplegia, no? So paralysis of the entire body or half, emotional ability, nalikam sa masuko, visual changes, hemonymous hemianopsia, no? Tunga ra sa mata ang makita. Horn syndrome, ptosis of the eyelid, no? And then vomiting, perceptual defects, CVA right hemisphere, hypertension, apraxia, no? Decreased learned movements, and also not kaning TIA. We'll talk about TIA later on, okay? Now, modifiable risk factors. So hypertension. So these are the modifiable. So factors that can be changed. So hypertension. So diabetes mellitus, obesity. So obesity, you can exercise to reduce the risk for stroke, no? Substance abuse, smoking, atherosclerosis, diabetes, because it, nagkuing molecules of sugar. Yeah, some patients might have multiple organ failure, like your liver, the clotting nimo maguba. So smoking is also a risk factor. Atherosclerosis, cardiac valve disease, atrial fibrillation, carotid artery occlusion. So if you're one of this, obese and smoking with hypertension, DM, tell them to modify. So up to 80% of strokes are preventable by managing risk factors. Can you see ang risk factor? And these are the non-modifiable risk factors: age, gender, race or ethnicity, and family history of strokes. Kani sila but no, so di na ka maka-modify ana. Knowledge transfer, true or false? This is knowledge transfer number 2. Obesity is a non-modifiable risk factor. True or false? Non-modifiable factor for stroke. So in stroke, we have this thing called FAST. So FAST is face, arms, speech, time. So we start with face. Okay, one side of the face is drooping. So saan mo ni pag-assess? So yung muna pasyente, can you smile for me please? Pas man so kita ni mo saman. Kita ni mo nga symmetrical ang facial expression. Smile niya ang usa mo ana din niya, ang usa ka ana. Okay. Next is arms or leg weakness. Ingnon pasyente nga isa ang kamo, no? Or squeeze my hands. No, di maka-squeeze imong hands. Di makaisa sa tiil. So meaning to say kanang pasyente ha kay possible na nay kuan stroke. Speech, na siya speech difficulty. Di siya ka sulti, no? And T is for time. So call ambulance immediately or call 911. In the Philippines we have 911, I believe. So na uban gitawag nila B fast na nila sad. So B to include balance, loss of balance, headache, sudden or thunderclap headaches, or dizziness. So ang pasyente nga gi-stroke, ang pinaka first na ko nga nakita is balance, no? And nisuka siya, no? And blurring of vision din siya makita. So once B fast happens, T then it's time to call. Kung nasa balay ang setting, nasa balay, or kung ang setting nasa ER, inform your doctor immediately. Delays in stroke symptom recognition vastly reduce the time of treatment, and as nurses, we are in the best position to detect stroke. Okay, kita mang nasa kilid sa pasyente. Eligibility for thrombolytics. Delays in stroke symptoms recognition vastly reduce the time. Eligibility for thrombolytics, and endovascular treatment, which increase the burden of disability on the patient. If stroke symptoms are suspected, emergency care should be expedited emergently. So mag-abot sa pasyente sa emergency room, mag-assessment ka kung vital signs pa lang daan, alert oriented. So kung kung vital signs, kung ano vital signs, ma-assess ka orientation, alert oriented times 4, unya ma-assess pa jud ka og kuan kanang pain na mo niyo buhaton by asking the orientation hibaw ano ning pack stroke ni kay na confused ni dili good siya confused before. Now stroke care begins in the community and the pre-hospital settings. Balay pa lang daan, no? Atong sige na salida sa ABCBN nga bantayan nila nga na stroke na daan nila sa ospital, no? And public education, the signs of stroke can be fast. You can teach your family with this. Can be conveyed using this thing, the FAST, no? Face, arms, and speech, and then time. Now TIA, the one I promised that I will discuss. TIA is different because it is sudden onset of neurologic dysfunction resolving within 24 hours. Diba mo pasyente matug ER, nakuha ko nilang mata, tunga nilang makita, and then paabot na sa ER, na resolve, na wagtang. So, nabalik ra, full na, no? So, up to 10% of patients experiencing TIA will have a stroke within days. So, always remember that. It's a good thing yan to sila ER, no? So, baka na sila, padaganan din sila og mga blood test. Up to 20% experience stroke within the next 90 days. So, so better nga madong na kay TIA. So, what is the difference between TIA and CVA? Maoni. Okay? Sa CVA, sa mga nakita na ay it's either bleeding or it's either occlusion, no? Hemorrhagic and ischemic. And here, TIA, kay naalay temporary nga na block. Might be blood clot, gagmayng blood clot, nana. Okay, so ischemic stroke is one usa ni sa mga types of stroke. 87% of stroke is ischemic. So meaning to say bleed, no? It occurs as a result of vessel obstruction from a thrombus or an emboli. So thrombotic ischemic strokes are the result of atherosclerotic plaque build-up in vessels. So, if there's a plaque build-up, na siya gitawag bifurcations and curves in the vessels, and they put the vessel particularly at a vulnerable state. So when an occlusion causes diminished blood flow that is unable to meet the demands of cerebral tissues, ischemia results. The center of ischemic cells is surrounded by hyperperfused tissue known as the penumbra, and the penumbra may be rescued with early reperfusion. So ischemic stroke, sa ito kong ganihan, ischemic stroke ay kuan. May blockage and resulting to loss of oxygen supply to a surrounding tissue. So in the area we call it penumbra. So there are signs and symptoms of stroke depends on the area of involvement. So ang kaning anterior cerebral artery, so anterior cerebral artery, this one here. Itong i-on ang ako ang kanbe. Laser pointer. This one here, this area here. Okay, patient will have collateral paralysis of the foot and leg, impaired gait, no sensory loss of foot, toes, and legs, lots of willpower and perseverance. No, kana mana siya. Na most na mga hug na sila. Kay gihan sila mulakaw. Kaya na usay mga maglibog kang trabaho kag ER, maglibog kang mga tawo ang ginahan mulakaw. Ang tawo nga dili pwedeng palakon ginahan mulakaw. Ang mga tao nga ginahan nga pahigdaon, ginahan mo bangon. So, mao na ang anterior cerebral artery. Mga hog na sila pero may sa bed. So, we have to be careful for false risk. Next is the posterior cerebral artery. So, na posterior cerebral artery. This one, blue. This one here, this area here. So, memory impairment, visual deficits, harmonious hemianopsia, matong mata, matunga na lang makita, color blindness, loss of depth, and perception, inability to recognize objects as well. Agnosia ba to? Kana siya. Yeah. So the neurologic deficits observed in stroke depends on, as I've said, area of that are affected. Now, middle cerebral artery. So sensory impairment, hemiplegia, homonymous anopsia, and global aphasia if dominant hemisphere is affected. This one here, this one, or this one. Okay, vertebral artery will cause dizziness, nystagmus, dysphagia, facial pain. No, sakit akong naw. No, maragitang paros akong naw. Then neurologic ang pain, sakit. Ataxia, clumsiness, no, nagkaon ginagkatag, no. Basilar artery, tetraplegia, anterior inferior cerebellar artery, kay nausea, vomiting, nystagmus, ipsilateral paresis or lateral conjugate gaze, contralateral impaired pain, and temperature sensation in trunk and ribs. So, ischemic strokes and symptoms still left-sided. Kung left-sided na nga kuan, left-sided sa brain, so natay right kay opposite man. Diba ang nerves na to mo cross man dinhi. No, mo cross man dinhi. Kalimot ko sa term sa pag-cross ana. So, cross ana kung diri ang affected, ang affected sa body kay ang right side. So, if left side sa brain ang affected na ay right-sided hemiplegia. Okay, na ay receptive, expressive, or global aphasia, na ay intellectual impairment, and slow and cautious behavior, and deficits in right visual fields. Okay, kung right-sided ang affected kani, left-sided hemiplegia here, na ay weakness tining napita, no? Ibuam na nimo kay yung pasyente nga, can you squeeze my hands please? Yung squeeze nila kang dinhi kay dili kusog. Kanira ang kusog kanina hinay. So, impulsive behavior, poor judgment, and deficits in visual fields. So management of stroke, initial management begins with ABC, so airway, breathing, and circulation. Oxygen is administered as needed to maintain saturation at over 94% and measure the blood glucose and administer 50 water, D50 water for glucose under 60 milligrams per TL or under 3. Complete stroke assessment under 4. Complete stroke assessment, establish IV access, draw blood to complete blood count, CBC, PT, PTT, INR, troponin, 12 lead ECG, chest x-rays, and non-contrast CT scan. And do not delay the CT of the head because that is the only way to get information kung ischemic ba or hemorrhagic stroke. So, and also get the 12 lead ECG. Remember how to place ECG? Huh? Sa ibutang dinhi, sa ibutang dinhi, sa ibutang dinhi, no? I hope you still remember that. So, if the patient is candidate for endovascular thrombectomy or intraarterial TPA, so saan yung pagkibaw nga candidate ang pasyente for sa CT, makita na siya. Okay, kung dili hemorrhagic, so kuan siya. Kung dili wala nag-bleed, so ang pasyente kay kuan siya. So obtain cerebral vascular CT scan. So the goal is to administer tissue plasminogen activator or TPA, which is currently the only thrombolytic for stroke treatment approved by US and Food and Drug Administration. So within 60 minutes of ED arrival, emergency department arrival, for patients meeting eligibly, but this medication should be started as much as possible, as early as possible. Okay? TPA can be stopped if laboratory results make the patient ineligible for TPA. If the patient is eligible for TPA, the medication is given regardless of plans for endovascular treatment. Blood pressure must be below 185/110 before TPA administration. IV labetalol or nicardipine is recommended to control your blood pressure. If the patient is not a candidate for TPA, so permissive hypertension is necessary to maintain cerebral perfusion. Sige, saka ang dugo dito, no? Nya, dili nimo immediately lower down ang blood pressure. May tabuan ang hubag ang utok kay kuan man. Wala na yung blood supply. IV labetalol or nicardipine is indicated if the patient is not in candidate for TPA, indicated for a blood pressure higher than 220/120 millimeters mercury, with a goal of decreasing the blood pressure by no more than 10% or 15% in 24 hours. Now, indwelling urinary catheter should be inserted before TPA. Kaya naman, this will cause injury unya magdugo na noon, or at least 30 minutes after TPA products is completed. Di pa ka mag-catheter. All patients diagnosed with stroke must remain NPO until a swallowing screening is completed by a trained individual. Timeliness to administration of TPA is crucial to improve the outcomes of a patient with ischemic stroke. Knowledge transfer number 3. The daughter of a patient with a newly diagnosed stroke asked the nurse if they can give the patient give their mom food. The nurse is correct if the nurse responds to which of the following statement. A. The patient must remain NPO until the SLP has performed a swallowing test. B. Of course, let me get a steak for your mom. So siya, Wagyu steak. On dayon. C. Only clear diet is allowed for patients with stroke like your mom. D. You need to thicken the soup that you feed to your mom. Okay? So, may buhaton, no? Hemorrhagic stroke. 13% of patients will have hemorrhagic stroke. And from intracerebral hemorrhage, ICH, a cerebral aneurysm, and arteriovenous malformation. Mo ni siya ang causes of hemorrhagic stroke. Hemorrhagic stroke is the result of bleeding into the subarachnoid space or intracerebral tissue. So these are ineligible for TPA. Kaya TPA makakause man o kanang blood thinning. So kung mo blood thinning ang hemorrhage, samot ng hemorrhage, matay ng pasyente. Okay? Small percentages of patients regain full function. Only a small percentage. Inyo nang ipasabot ng may pamilya na history of stroke. Mo nyo pasabot nga luoy kaayo, no? So ICH, intracerebral hemorrhage, is most commonly caused by hypertension. So kung may parents nga na high blood, inom og tambal, ina dyan same time each day ang pag-inom og tambal, no? Other causes are stimulant abuse, drugs mo, rupture of an aneurysm. Mga ubang mga tao mamatay mag-drugs after nag-stroke, hemorrhagic, no? Brain tumor, coagulation disorders, and an anticoagulation use. Anong nagamit mo mga substances nga blood thinners like heparin, no? Signs and symptoms: onset of neurologic function, headache, vomiting, rapidly deteriorating level of consciousness. Signs and symptoms: sudden onset of the worst headache of my life. So, meaning ang pasyente mo, present nimo, means like, I have the worst headache of my life, meaning to say, so you suspect that's either migraine or that's, what do you call this, stroke. I always, tanang pasyente na mo, ng matug ER, presenting with a headache, unahon na mag-assess. Okay, that could be a possibility. There could be a possibility that the patient has stroke. That was maximal and its sudden onset and frequently followed by a nausea, vomiting, deteriorating level of consciousness. This is what you do. Stroke. Always remember this. As a stroke, naging neurologic dysfunction. No, fast. Gamito ni mga word nga fast. Another thing ako nakuhanan sa stroke, pasyente nga na stroke. Another thing akong nakita, kaya nas na anxiety. First signs and symptoms of anxiety. After that, masuka na ng pasyente. No? Nauseous. Not responding to any medication sa anti-nausea medication. So, you suspect na sila stroke na headache, sudden headache. So, muna stroke, alert na dyan mo na, no? Kaya mo pag naglain, no? Tawag na mo race, or tawag na mo sa doktor, or puhot o tawag o code blue. A non-contrast CT will show blood in the brain, parenchyma, or subarachnoid space. Lumbar puncture of a patient with SAH will reveal bloody CSF. No? Dugo. Normally, wala dugo ang CSF. Kaya naman na may blood-brain barrier sa imong utok. Cerebral angiography may be completed to identify the source of bleeding. Hemorrhagic stroke management. So initial management begins with securing ABCs. So airway, breathing, and circulation. So rapid intervention to stop the bleeding and reduce ICP is required to prevent brain herniation. So unsay mga signs and symptoms and then prevent death. I have a patient before. He was 23 years old. 23 years old. Engineer, software engineer. So siya lingkod work at home just during COVID, okay, pandemic. Work at home, unya nakita na siya barog. Pag barog niya, buto siguro to somewhere there, nagkuan siya, nag-stroke, no? So, they call it mini stroke. Pada sa hospital, then that night, ako'y nag-care sa pasyente. So, pag-care na ako sa pasyente, kanang siya katugon, tug siya, gusto siya matug. But first, tagad pa siya na ako, say hi, katug alas 10 sa gabi, si katug ni doctor, I think the patient is kind of sleepy, decrease yung LOC. The doctor said, natug ng pasyente kay gabi naman. So nurses are always in the bedside, doctors wala man na sila sa assess. Nakaingon na dyan nga, wala gini akong gipukaw pasyente one point, akong gipukaw pasyente niya, pagpukaw na ko niya kay kung hello, di mo mata pasyente. So, nitawag na rin ko, naikinhawa na, paghapoy pulses, naigin na siya kuan, pero wala na, tawag ng doktor, ng pasyente na yun. So, mo to, gidali og CT scan, naibawaan nga na siya brain herniation. So, gi-transfer siya another hospital, transfer niya sa line hospital, kay, kuan na siya, kaning procedure, gitawag og, ventricular drain, no? Ventricular drain, bangagan ng utok. Nagsuy na ko sa Pilipinas when I was in the Philippines. Nagsuy ko assist og mga pasyente sa neuro ventricular peritoneal drain, inibutang, no? Aron ma-decrease ang pressure, dili na mag-brain herniation. Always remember, kung na brain herniation, katugo ng inyong pasyente and decrease in OLC will be the signs and symptoms. So emergent reversal of antithrombotic may be necessary. Administration of vitamin K. Blood pressure management is needed. Insertion of external ventricular drain permits measurement of the ICP and drainage of CSF to reduce intracranial pressure. So, mauni ang naong ana niya. So, this is drill bits. no? Bangagan. Fun facts sa drill bits kung ang purpose niya kay iyang bangagan ang imuhang skull. Once nga mo hit siya o soft tissue mo stop na siya. Na siya yung mechanism. Okay? So, hemorrhagic stroke management still keep the head of the bed elevated, maintained in the midline position, administer pain or sedation medications kay anxious ninyo pasyente ana. Reducing stimuli, providing osmotic diuresis with mannitol or hypertonic saline. Normal blood glucose and core body temperature should be maintained. Tidal CO2 monitoring is indicated to maintain eucapnia. Anticonvulsants are added if seizure occurs, and patients are maintained in PO until a dysphagia screening is completed. So, for the analysis check, kung si answer adto, no, maunay go back sa analysis check, maunay ang answer ana dito. Next is seizure. A seizure or epilepsy. What's the difference between a seizure and epilepsy? So a seizure is a sudden abnormal excessive discharge of electrical activity within the brain that disrupts the body's usual system for nerve function. Mo na seizure. It is acute. It is sudden. Ang imuhang epilepsy is more on a chronic disorder characterized by recurrent seizure activity, no? So seizures are often the first manifestation of an intracranial mass, no? Kita niyo yung pasyente nga ni kirig, no? Kung ano nga anay mass. So to ipasiti dayon na sa doktor. Knowledge transfer. What is the difference between seizure and epilepsy? A, B, C, or D? Three phases of seizure. So first phase is what we call the prodromal phase. So prodromal phase consists of mood or behavior changes that can precede the seizure by hours or days. No, pasyente, mahilo mo ng pasyente, kalit, masab yung behavior, no? Pasyente. In some individuals, an aura, of course. An aura is a sensory warning, no? Such as, more Spider-Man ba? Nice sensory warning. Such as a taste of smell, or metallic taste in the mouth, or a flash of lights. No? Masyagi picturan. Picturan sa mga paparazzi. No? So, may tabuan na mo ni ang aura. So, each patient has a different aura. May uban nga nakasmell og sunog nga kuan. So, mo ni siya ito og prodromal phase. Next phase is the second phase or the ictal phase. The seizure activity itself, the ictal phase, seizure activity itself. And the third phase is the post-ictal, no? Follows the seizure. It follows after the seizure, okay? Now, international classification of epileptic seizures. So, partial focal seizures. Partial focal seizures is subdivided into two. We have the simple partial seizures and the complex partial seizures. So simple partial seizures occurs in about 15% of patients with seizures, and signs and symptoms of this is motor, cognitive, sensory, autonomic, or affective deficits depending on the area of cerebral cortex involved. Complex partial seizure, which occurs 35% of patients with seizures. Signs and symptoms is that its consciousness is impaired partially or completely, but no initial generalized tonic-clonic activity. Tonic-clonic, remember the word? I'll explain that later. Clinical presentation carries, but usually patients experience an aura, automatism, post-ictal confusion. Automatism ganang masyag ganang kuan ba yung lawas mo lihok lang against ng automatically. Kuan siya. They will have no memory of the events during the seizure. Okay? Complex partial seizure. Generalized seizure are the manifestations of generalized seizure, by the way, is 40% of patients suffer from generalized seizures. This is a manifestation of generalized seizure that indicate involvement of both hemispheres, left and right. Most commonly impairment of the conscious and bilateral motor movement. Patient usually have amnesia of the event, so it's lang makahinumdum, no? So Unclassified seizures, they occur for an unknown reason and do not fit into the partial or general classifications of the seizure. Types of seizure. So type 1, not type 1 like diabetes, absence. So petit mal, absence. Of course, in 5% of patients with seizure, especially in children, no? Kahit nagtagtunga nga, tanaw sa bungbong. No body movements may occur, no convulsions or post-ictal signs or symptoms. No, that's what we call absent seizure. Next seizure is atonic, no? Drop attacks, sudden loss of postural muscle tone, no? Next is myoclonic, so brief symmetric jerking, kirig sila, of the extremities that usually involve the upper extremities, so only the upper ones. Clonic, repetitive rapid motor activity. Tonic is rigidity. So clonic, tonic, mukurog sila, repetitive, unya manggahi. Imagine mo na. Namistingan sa una nga tawag nila patulon, no? Maluoy taon ko kay mukait magsyag-syagit sa kuanda. Kaya makita siya aura ba? Masag-ub man to siya sa among puso sa una. Nya, makita siya aura. Ang siyang aura, makasyagit siya dayon. Kirig din siya dayon. Gahi to ni clonic kay magahi gid siya. Gahi o kan repetitive nga kuan. Tonic-clonic, tonic-clonic grand mal seizure is of course it is a 25% of patients with seizures. No, 25% of patients will have tonic-clonic. So the most common type of generalized seizures. Tonic-clonic followed by jerking movements may produce cyanosis, labored respirations, bowel or bladder incontinence or both, and involuntary tongue biting and post-ictal fatigue, confusion, or stupor. Causes of seizure. No? So ani ang imuhang tonic-clonic seizure. Okay? It can be triggered by toxic states. Okay? Electrolyte imbalances. No? Tarong inom o mga juice, electrolytes, sodium, potassium. Anoxia. No? Cerebral tumors. Inflation of the CNS tissue. Hubag ng utok. No? Cerebral vascular disease. Hyperpyrexia, wala mga bata sobrang kainit 39 degrees Celsius di bigay inon og tambal kay kuan kuno kanang nakuno side effect ng tambal, no? Kuno di nila pa emnon mo na ang kirig ang ilang anak. Increased intracranial pressure, no? Trauma, hypoxia, Huntington's disease. Mo kita kung saan Huntington's disease. Imagine nga ang bata ang nagkanang masya sa sayag ba. Multiple search sa YouTube. Multiple sclerosis, Alzheimer's disease, idiopathic causes. Okay, mga causes of your seizures. Myths and stigma associated with seizure. People with epilepsy, people who with epilepsy are called stupid. Stupid ay buang, no? Karang sa mga Pilipino kay anak. I don't know why, for some reason we're very rude. Among mga silingan, no? Di lang ta malayo among silingan, no? Rude kaayo, no? Ito ang silingan na patulon ay it is contagious, makatakod, dili makatakod ang seizure, gigabaan, no? Methods, gigabaan na rin huwag na siya nagpakuha, no? Dili na siya tinuod. Myths and stigma associated with seizures are usually not true. Tarbang mga Filipino, kusog kita mo to mga chika-chika, mga false news, inahan kitaan na kanang mga mga story nga walay basis but interesting, inahan kitaan na. So we need to stay away from that. Okay, people with epilepsy are crazy. People with epilepsy cannot participate in sports or other normal activities of daily living. No, employer nga Filipino di mo hire epileptic kay mga hug pa lang nung nadihan kuan steak sa os pasyente, sa ilang kliyente, no, anak. Employees with seizure have a higher rate of on-the-job injuries and absenteeism. That is not certainly true. And namte mga tambal that prevents seizure. All of them are, once again, are not true. So diagnostic test for seizures. So usually we get blood test for electrolytes because we believe that the cause of seizure is an electrolyte imbalance. Others are arterial, like partial oxygen levels, because we thought that it's hypoxemia. And EEG, so electrocardiogram, this is not electroencephalogram. So this is a definitive test to diagnose seizure activity and can determine the presence of a seizure focus. No, asa lapitan ang seizure. So good. It measures electrical activity of the brain through electrodes placed on a scalp. For a 24-hour EEG, it is a 24-hour EEG is necessary in order to derive a diagnosis, a definitive diagnosis of seizure. Instructions, the only nursing instructions for patients who will go EEG for nurses, kay kuan, to instruct the patient to stay up late night before EEG and to be awakened early. And for a sleep-deprived EEG, children and infants should not be allowed to nap before the scheduled test. And your only nursing specific care is to shampoo the patient's hair to remove the electrode gel after the EEG. Now, treatment. The medication is the hallmark of seizure management. 75% of seizures are usually controlled by anticonvulsant drug therapy. And these are the examples of anti-epileptic medications. Carbamazepine, Tegretol, mga common na ang mamutang ha. Clonazepam, Klonopin, very common ni siya. Gabapentin, Neurontin, Lamotrigine, Lamictal, Levetiracetam. This is the most common one. Keppra, no? Nasa tay Keppra nga blood test to determine if the cause of this seizure is an overdose of Keppra, no? Phenobarbital, phenytoin sodium, sigara mga tiguang ma-overdose sa Keppra, and valproic acid, no? Depakine. Knowledge transfer. What is the number 5? What is the hallmark of seizure management? A. Restraints. B. Padded tongue depressor. C. Padded side rails. D. Medications. Seizure precaution. So yung imong pasyente nga nag-seizure, it will be placed in a seizure precaution. So how do you institute that one? In most institutions, it is recommended that oxygen and suction equipment with an airway be ready available on the patient's room. What is an airway? Ito bitang curve ng isok-sok sa baba sa kanang mag-surgery. So air na. IV access at all times for a patient with a history of seizures. Okay. How do I ask a patient with seizures? Ask them directly, do you have any history of seizures? Padded side rails can be a source of embarrassment, so always be conscious about it. Ako din, nakapasyente ko ang padded og side rails. Bed must be in the lowest position at all times. Initial treatment of seizures, padded tongue blades are rarely kept at the bedside because they should not be inserted into the patient's mouth in an active seizure. No? So, kung na seizure na, pwede namin ibutang. I remember sa una, kita ko nagdugo ko ng baba sa ako ang pasyente. Ibutang sa Pilipinas to ha. Giduot ang giduot. So, nagdugo. No? So, never. No? Especially kung nagsugod na. Nurses must note that the type of seizure activity and the events that surround the seizure in order to determine the best plan of care. No? Note the type of seizure activity. No? Tonic-clonic ba? No? Absence ba? Protect patient from injury and patient movements guided by FSR. Remove objects that are in the patient's way to prevent injury. Do not restrain your patients. Remove restrictive clothing. Do not force tongue blade or airway into the patient's mouth, and turn the patient to his or her right side and suction the patient if needed. Okay? According to Schumacher and Cherky to 2010 in their book Emergency Nursing, kay ipa-turn sa right. Akong nibasa sa internet, ipa-turn sa left. Kay ingon ang Red Cross, the recovery position is to the left. So either left or right na mo supporting details ano niya. Okay, I'll follow the right one. Kaya ingon man si ingon man si Schumacher and Cherny 2010. Hindi siya 2010, 2020 siya. This is 2020. Initial treatment of seizure still. At the end of the seizure, human na sa seizure, mong buhaton kay to check vital signs. Mga nurse excited kaayo once while seizure pa, nasigig vital signs, no? After the seizure. Perform neurologic checks. How do you perform neurologic checks? Ask the patient for alert on orientation. What is your name? What date is today? Did you know what happened? Keep the patient on his or her right side. Allow the patient to rest. After then you document. So what are the things that you need to document after seizure? So a patient found on the floor, seizing, actively seizing, morning a time, the onset, duration, frequency, and number, state of consciousness. Kasi gabang na awake mga pasyente. Yung mga napot na pasyente, nakinamdam kasi na itabo, usually may tagwa. Eyes and tongue, teeth, motor activity, body activities, respiration, drug responses, seizure awareness. In the emergency department, kasi garanjod nga magka-seizure ka na yung mga hilanat. So be careful mo na. No? Hilanat, 37 point, sa mutong-tong na ginag 37.8, musugod na mag-medicate sa patient. Okay? Knowledge transfer. Number 6, a nurse saw a patient having an active seizure on the floor. What will be the nurse initial reaction? A. Immediately shove a padded tongue depressor in the patient's mouth. Okay. B. Call the doctor immediately and document the situation. C. Turn the patient to the right side and ask for help. And D. Call code blue. So after seizure, we move on to epistaxis. So epistaxis, otherwise known as nosebleed, epistaxis or nosebleed is seen frequently in the emergency department. So the causes of nosebleed are the following: infection from not washing your hands and picking your nose out, and also trauma, local irritants. Cocaine may cause epistaxis. Foreign bodies that goes into your nose. Anticoagulant drug therapy, congenital or disease-induced coagulation disorder, tumors may also cause bleeding, URI, upper respiratory infection, nose picking. This is the most common cause according to Sweet and Fohe in 2020, and forceful blowing of the nose, high blood pressure, dry weather conditions, especially here in Canada. The American Red Cross considers this as cause of epistaxis. So there are two types of epistaxis, the anterior epistaxis and the posterior epistaxis. So the anterior one, usually very acute. It originates in the Kieselbach's plexus. This is a highly vasculated area of the anterior nasal septum. Next one is the posterior epistaxis, usually chronic and common in older adults. Bleeding is more profuse, involving posterior branches of the sphenopalatine artery. Hypertension can worsen the bleed, but has not been shown to cause epistaxis. But according to Red Cross, this is a cause of epistaxis. Hypertension is a cause of epistaxis. But I believe in Sweet and Fohe 2020 because this is an ER emergency room nursing. So emergency nursing. So they said that hypertension can worsen the bleed, but not shown to cause epistaxis. In mild cases, bleeding may stop spontaneously within minutes or by simply pinching the nose. Bleeding may be profuse and continuous with potential for hypovolemic, requiring aggressive management and ENT consult for embolization. Management of epistaxis. The patient usually presents clutching bloody tissues or towels to the nose and can be extremely anxious. So some of these patients are angry. I have a patient na-admit sa ED. Niya, sigto ang iyang dugo, no? Niya high blood pressure, pag hypertensive, pag na patient. So, dali pa siya masuko. No? A calm and reassuring systematic approach by which the emergency nurse helps ease anxiety and allows efficient management, no? So ay karatol kay sa mga karatol maratol pa pasyente niya ratulon pa jud kas pasyente. So kasi karon yung mga pasyente kay dali ila masuko Nya, igtan-on na nimo, mingon silang, ano wa man ka magdali, inana. Ganan. Kani nga mga pasyente sa emergency department, ginahan sila nga, ikaw, madigandagan ka, magkarak-karak ka. Kay, by that, masatisfied sila ba nga, kinahang na, ako kay, usually, mga ER patients, ay ER nurses kay mga kwan kayo, chill, no? Chill kayo ba? Yung mga ma-feel sila, wag na sila magdali, ay, nana. Observe universal precaution, including gloves, goggles, masks, and gowns, when you take care of this patient because of the risk for splashing. Maintain the patient in an upright seated position with the head tilted downward and nostrils pinched. This is how you deal with nosebleed, okay? Like that, okay? EBCs is one of our priorities, and initiate appropriate interventions such as suction, IV access, cardiac monitor, and oxygen saturation monitor. So, sige mo suction, sige ka kuha niya samot og bleeding, no? Obtain blood sample, CBC, pwede din makita na kay hemoglobin, prothrombin time, partial thromboplastin time, type and cross-match, as ordered. Treatment for anterior epistaxis begins with identification of the bleeding site, no? Anterior bastia or posterior, followed by application of topical Afrin, direct pressure for 5 to 10 minutes, and a chemical silver nitrate or electrical cautery and packing if necessary for this patient. Some patients may require anxiety medications kay ang stress sila. Hadlok mo, ikaw gumakita dugo sa imong ilong, no? Nasal packing may be done with standard petroleum iodoform gauze or newer commercial products mo na ipack sa ilong, no? Anterior nasal packing is left in place for 48 hours. Muna ipautana sa pasyente. Nos atang taon, mapagit pagsugod sa packing, mapagani pagkanang kuan, kanang tawag ana, mapagkuman yung packing, mutana din nos at pwede lang tangon, no? Nana ka-annoying sometimes ang patients sa emergency department. The patient should follow up with ENT or return to ED immediately for persistent bleeding or dislodged nasal packing. So, kung hindi na may ginani, among gipack, gi-send home, niya giinan nga, niya itagaan o ka ng ENT referral, niya nibalik kay nasigod magdugo. Kadali kayo masukugod. High blood kay ba? Posterior epistaxis is more difficult to manage and requires insertion of posterior nasal packing or a balloon catheter. This is what you see here, this one. So, isod niya sa ilong, niya kaning duha, mugawas ni sila. Mao ni siya, dini ka mag-inject og air or maborot ni. Okay? Mao na siya. Kita na ko ani, ngibutang sa uwan. So, ang patient ani, ginhawa na silang baba, no? Posterior epistaxis is more difficult to manage and requires insertion of posterior nasal packing or balloon. These devices should be removed within 48 hours. Posterior nasal packing predisposes the patient to hypoxia, so admission is necessary for monitoring of airway, sedation, and cardiac effects. Surgical ligation and of vessels may be required to control of severe posterior epistaxis and hypertensive agents may be needed for a patient whose blood pressure remains elevated. With severe blood loss, blood transfusion may be necessary. Complications of epistaxis is hypoxia, dislodged nasal packing, airway occlusion, hypovolemia, severe discomfort, of course, especially kung ay balloon dito, sinusitis, toxic shock, cardiac dysrhythmias, and respiratory or cardiac arrest. Knowledge transfer. Number 7, a patient has a nosebleed. What will be the nurse's initial intervention? A, press the code blue button. B, pinch the patient's nose and reassure patient that nosebleed will stop in minutes. C, turn the patient to the right side to facilitate drainage. And D, administer heparin as prescribed subcutaneously. Headaches, okay, a complaint seen mostly in the emergency department. However, very few headaches are associated with emergency medical conditions. But if you have headaches, kailangan inyo na siyang i-treat ninyo with caution because some stroke may present itself as a headache. So headache is not a disease but a symptom of an illness or an injury. Hold on. Okay. So these are the life-threatening causes of headaches: subarachnoid hemorrhage, venous sinus thrombosis, temporal arteritis, meningitis, and carbon monoxide poisoning. Headache assessment include the following: include the onset of symptoms. Don't forget to ask, when did it start? When I assess a patient in ER, I do vital signs, I do like stuffs, and then I ask them, what made you visit the emergency department today? And then if they say have a headache, then I'll ask, when did this headache started? What is the duration? Is it on and off? Is it where's the location? What's the pain score? How do you describe it? Is it aching, crushing, sharp, pulsating? Intensity, pain description, duration, preceding events associated symptoms, nausea and vomiting, something like that. Sudden onset of the worst headache of my life, which was sudden at onset and maximal at onset, is a red flag signaling a possible subarachnoid hemorrhage or SAH, predisposing to what? Stroke, hemorrhagic stroke. So basta may ganit sudden worst headache of my life, kailangan inyo nito ng ating manundayan. Now let's transfer number 8. A patient came to the hospital and complained to the nurse, "This is the worst headache of my life." What will the nurse do? A. Administer Tylenol 975 mg for pain. B. Call the doctor and inform about the nature of the headache. C. Perform a focused neuro assessment. And D. Call code blue. Focus past medical history. So injuries or diseases to aid in determining an underlying cause of headache are the following: prior history of headaches, no? Basin migraine and siya, hypertension, ventriculoperitoneal. So when I assess for hypertension, I ask for headache, no? Usually mo na yung signs and symptoms put ventriculoperitoneal shunt, no? Histories of brain surgeries before, seizures, recent infection, and prior cranial surgeries. Causes, so extracranial. So natay duha ka causes, extracranial and intracranial. So in extracranial, obviously it's outside of the cranium. So extracranial causes include the following: dental problems, TMJ, temporomandibular joint issues, visual reflection problems, no? Say ang mata mo sakit na tungod sa glasses or sometimes sa glaucoma, sinusitis, cervical strain, fever, hypoxia, anemia, hypertensive crisis, allergies, heat-related illness, dehydration. Oh yeah, dehydration, no? Di mong tarong inom mo, sige mong trabaho sa ER, nakalako, inom tubig, it will cause dehydration. Mana mo break dyan mo, mana magka-headache mo. So sometimes, if you have a headache, especially when you're a student as well, mo mag-duty mo, kalimut mag-inom ng tubig, mo sa head niyo. So una sa student, sige kung headache, so mo ito. So you just need to drink water, no? Or anything that has electrolytes in it. Other causes, extracranial causes, are trigeminal neuralgia, no? Kanang sa naong, no? Masakit yung naong, lumbar puncture, concussion medications, disruptive sleep patterns, ikaway tug, no? Night shifts, and psychosis. No? Intracranial causes is migraine headache. Let's talk about migraine headache later. Tension headache, cluster headache, temporal arteritis, and trauma. Diagnostic evaluation for patients with headache is focuses on confirming the cause of headache. No, so we don't have a definitive diagnostic evaluation, since this is this is not a disease but accompanies a symptom of disease. Okay. Next one is migraine. So what is a migraine? So according to NHS in the UK, migraine is a moderate or severe headache felt as pain in one side of the head. So is the most recent evidence indicates that this is a result of impaired nociceptive processing. Okay, patients are encouraged to keep a headache journal in an attempt to identify triggers. So migraine may be triggered by food, no? Spicy foods, dieting, diet ka, nag-migraine, hinoon ka, among na lang, no? When you're a student, don't do diet, yung ano man, tuon ka, your brain uses glucose, you don't need another problem, right? Emotion, no? Hyper emotional, sikay ka, no? Menses, medication, weather changes, especially here in Canada, sleep disturbances, no? And bright lights like this. Signs and symptoms of migraine: still moderate to severe pain lasting 4 to 72 hours, usually at a unilateral location and described as pulsating or stabbing. May include nausea, vomiting, photophobia, and photophobia made worse by activity. Knowledge transfer number 9. What is the difference between headache and migraine? Select all that apply. A. Migraine is a moderate headache described as a throbbing pain on one side of the body. B. Headache is a symptom of a disease or an injury. C. Headache can also occur in any parts of the body. B. Migraine is an act of God. Treatment recommendations: metoclopramide, manigsagaran ihatag sa pasyente nga na ay migraine or headache. Metoclopramide or prochlorperazine, subcutaneous sumatriptan, diphenhydramine or midazolam may be given to prevent or threat of akathisia. IV acetaminophen, aspirin, baka dungog IV aspirin. Acetaminophen, Tylenol, aspirin, chlorpromazine, ketorolac, and valproic acid. Nagsigaran ihatag, no? Oh, tagaan dyan ako pasyente dayon og headache gani, tagaan din ako og 975 milligrams of Tylenol. Opioids are given in 50% of ER visits, but studies show opioids to be ineffective in treating migraine. Dexamethasone too, steroid, shows potential to reduce the incidence of recurrent headache. IV fluids is necessary if there are symptoms of dehydration, and patients with chronic migraines should be managed as outpatient and have preventive treatments. Always encourage them to visit their family doctor. Next topic is care of patients with GI emergencies. So this is part 2. First GI emergencies that we'll be talking about is aortic aneurysm. So aortic aneurysm, have you heard of the word aneurysm? Is an aneurysm that is dilated area of the artery, at least 1.5 times is normal, and caused by weakness of the arterial wall. So why does aneurysm occur? It can occur anywhere along the aorta. You know where the aorta is? I'll show you a picture later on. And are generally caused by atherosclerosis and related factors such as infection, smoking, hypertension, trauma, hyperlipidemia, diabetes, syphilis, and heredity. May kaliwat nga na ay aneurysm. Abdominal aortic aneurysm occur more often and seen more often in men. There are 3 types of aneurysm. So in here you'll see your normal this is your normal aorta here, okay, and this is the aorta with abdominal aneurysm kani. So when you palpate this area here, mana importante jud ng palpation, wala pa gyud mawa ang ITPA, maka-feel ka pulsations na strong pulsations, auscultate sa dimo, makadungog kog swishing sound, mo na ang kuan ang kanang aneurysm, abdominal aneurysm, aortic aneurysm. Fusiform, the 3 types of aneurysm. Number 1, fusiform, characterized by a segment of artery dilated around the entire circumference of the artery. We have the saccular, dilates only a portion of the artery, and dissecting, most common one, results in a tear of the artery's minimal layer. And a tear allows blood to flow between the intimal and medial layers. There are 3 types of dissecting. Type 1, Dissection occurs in the ascending aorta and extends beyond the aortic arc. Type 2, dissection occurs only in the ascending aorta. And type 3, dissection begins distal to the left subclavian artery. So patient assessments for patients with aortic aneurysm or abdominal aneurysm is that the signs and symptoms depend on the location and size of the aneurysm. It is very uncommon for patients to have early symptoms, and some may be totally asymptomatic until a rupture occurs. So, monay nakabati aning aneurysm because this one here, until ruptures occur, nakamakibaw na kay aortic aneurysm. So an abdominal aortic aneurysm may be discovered during the physical examination when a pulsating mass felt while palpating the abdomen. Patients with a leaking or rupturing abdominal aortic aneurysm may have a classic presentation characterized by extreme back pain, accompanied by abdominal pain and tenderness with palpation. So back pain may radiate to the legs, groins, or lower back secondary to stretching of the anterior spinal ligament. So patients with dissecting thoracic aneurysm may complain of excruciating, ripping, substernal chest pain with radiations to the back, no? Here. And stridor, cough secondary to pressure in the trachea, no? So kung nakikita chest pain, consider number 1, naay MI, naay pneumonia, naay aneurysm. One time, akong pasyente nagkatawa while I'm asking questions about my assessment. Sige katawa. She felt funny. Why are you laughing? You shouldn't be laughing because I'm assessing for stroke and I'm assessing for aneurysm. Sige katawa, no? If they think that our work is, we're like clowns. Next, regardless of aneurysm location, patient may have severe apprehension, tachycardia, unilateral absence of major pulses, bilateral blood pressure differences, hypertension, hemiplegia, or paraplegia. Accurate initial and reassessment of vital signs, including comparing blood pressure and pulses bilaterally, here and here, okay, can give the healthcare provider valuable information regarding the aneurysm status. Diagnostic test for patients with AAA abdominal aortic aneurysm or any aortic aneurysm is a portable chest X-ray, just to confirm to rule out other diseases. So makita po niyo na kung naidugo na dito, no? MRI, magnetic resonance imaging, CT scan with contrast of the suspected area. So makita niyo sa CT scan na ay break, makita niyo ang aorta, yan ay ni gawas, no? Ultrasound, transesophageal echocardiogram, and angiogram. Mas angiogram mas kuno siya real-time view nga kung asa ang leak, asa ang bleeding. All patients, management for patients with abdominal aneurysm, all patients should be placed in high Fowler's position if hemodynamically stable, dili low ang blood pressure. Sa akong gito ninyo pagkibaw kung ang patient kay stable, we discussed this last time. So, stable ang pasyente kung iyang vital signs are normal, alert-oriented, pasyente, able to breathe by its own, dili up and down ang iyang mga vital signs. Given high flow oxygen up to 12 liters and have two large caliber IV catheters, duha gyud na, no, dinhi large bore. Okay, large bore catheter, IV catheters. The main goal in treating this patient are control of chest pain, anxiety, blood pressure. Close monitoring of blood pressure is very critical. If hypertension is present, drugs such as nitroprusside sodium can be used to maintain blood pressure at the desired level. Dissecting aneurysm often managed by beta blockers to control heart rate and blood pressure as low as possible. Systolic blood pressure is 90 to 120 millimeters mercury. If signs of hypervolemic shock is present, interventions would focus on maintaining ABCs, fluid resuscitation, and preparing for emergency surgery. So aneurysms are critical. This is an emergency. Okay. Next is gastrointestinal bleeding. Gastrointestinal bleeding is a symptom of an underlying disease. It could be from an ulcer or something else. Results from diseases that occur in esophagus. Esophagus is the most one of the most sensitive part of our body. No? So ayun ay pagbutag something sa imong esophagus, no? Small intestine and large intestine or rectum, such as peptic ulcer disease, Mallory-Weiss syndrome, pakitaan mo picture ana later, esophageal or rectal varices, neoplasms, esophagitis, stress ulcers, or inflammatory bowel disease. May also result from underlying clotting disorders, liver disorder. GI bleeding can occur without warning and be sudden or severe or have a slow onset. So it can be life-threatening if the cause of bleeding cannot be treated or controlled. How will you know that your patient has bleeding? I'll tell you later on the signs and symptoms. Anorexia, no? The first clinical manifestation are anorexia, nausea, vomiting, constipation, diarrhea, weakness, fatigue, general weakness, fatigue, weight loss, abdominal pain, discomfort, may precede GI bleeding and indicate underlying disease. So how do I assess this when I am talking to my patient? So when I'm talking to my patient, I do vital signs, I ask for orientation, mag-systematic na rin ko nga assessment, respiratory, neuro, nag-abot na ko sa gastrointestinal, mga tanong din ko. When is your last bowel movement? Did you have diarrhea? Did you have constipation? Did you have blood in your stool? Mana na yun ko. Mga related ko. Wala na ko anang mga chichibretching kung diretso na ako ang assessment anam, no? So, na ay blood. Sa mga color, bright red or dark red? Ang mata na ka na. Kaya kung dark red na, sa butan ang blood ni agi na sa GI system. Kung bright red, naran na sa tumoy sa anal area. Sumuha na siya. One time, katawan ko sa pasyente nga nung mga tanak ko dyan kuan na, ano. Ako sa siyang katawan kay kuan man. Importante man sa akong assessment. Causes. Peptic ulcer disease is caused by an imbalance of defensive and aggressive factors found in the stomach. The stomach's ability to renew and regenerate the lining requires adequate blood flow. So chronic ingestion of aspirin, alcohol, and NSAIDs weakens the gastric mucosal barrier against acid and pepsin action of the stomach, causing what? Bleeding. Presence of Helicobacter. You know what Helicobacter pylori? Mas like corkscrew. Ang lang ikog mo corkscrew. Mubangag na siya dito sa kuan. Sa imuhang wall, sa imong intestine, causing irritation and ulcers. Gastric and duodenal ulcers mo na ay mo pataka og kaon sa asa. Kanang H. pylori, meaning to say gikan na sa tao nga wanang hugas sa iyahang kamot after using the washroom or nakakaon na siya og kanang stool contents, no? Restaurant H. pylori nga infected, meaning to say ilang mga cook wala mahugas sa kamot, no? Ew. Once you have H. pylori, forever na naadid to. So acid, pepsin, stress, and smoking are also thought to be aggressive factors. Mallory-Weiss, so as shown by this picture here, turn on ako ang laser pointer right here. Mallory-Weiss is characterized by a linear tear of the gastric mucosa found at the stomach and esophageal junction, which is caused by retching during vomiting. Sige, retching. Okay, that's retching, no? Making a sound like vomiting. Mild to massive GI bleeding is a result of that. Mallory-Weiss. Sige mo retching. Magawa siya pasyente. Nako'y pasyente gabi aghapon, sige retching. Suka ng dugo. So, might be Mallory-Weiss tear. Endoscopy. So diagnostics for this type of patient is the following. Endoscopy so provides a direct visualization of the GI tract and the bleeding sites. So can be used to treat and control bleeding by obtaining biopsies and for electrocoagulations, ligation, sclerosis, or laser therapy. This is the gold standard for diagnosis of GI bleeding. So, pasyente ka nga mag-endoscopy gani, ayo pa kan yung pasyente. Unya, pasay na sa kuan, sa iyahang katong consent, and then do your pre-endo nga mga kanang kuan. Sa last kaon, last fluid intake, kanang sa nag-NPO, na ba siya ginom nga blood thinners, na mo na yung mga pangutan na sa imong endoscopy questionnaire. Next is esophagoduodenoscopy, EGD. Esophagogastroduodenoscopy is the visualization of the esophagus, stomach, and the duodenum. Okay? Esophagus, stomach, and duodenum, EGD. So may na-visualize ito kung naabay mga sources of bleeding. Colonoscopy is the visualization of the colon. Sigmoidoscopy allows for rectal visualization. And enteroscopy is the visualization of the small intestine. Upper GI series and barium enema can be used to diagnose GI bleeding. So, paimnon ka something, x-rayhan ka, makita dayad mo asa ang kuan. Upper GI series can be used to detect various ulcers, neoplasms, and inflammatory bowel disease. What is the difference? What is the difference between endoscopy and colonoscopy? So, endoscopy, ang scope ipagi sa baba. Okay? Unya, ay pa ka na yung pasyente, kung mag-endoscopy, na specific in your hospital will tell you pila ka hours, hindi pa kanon, usually ang mga kanang at midnight, aron makita sila dito. Kaya kung tangan mo pagkaon na diha, scope nila, ang ilang makitaan kay muhang pagkaon. Ang mapong kaning colonoscopy, ang prep niya kay kuan 4 liters of PEG. Kanang PEG, stool softener na siya, ilang imnon the entire night aron malimpyo na. Kay kung dili na limpyo, kung ang tae kay dili clear, inom nila atod nga ma-clear ang tae. Ang dili clear, ang makita sa doktor kay unsa man tae ang makita sa teleskopyo sa doktor. It will be a messy one kay mo pilit sa ilahang telescope, no? Now, diagnostics, dye can be injected via angiography to identify the site of bleeding. Para niya inyo makitaan sa PowerPoint diri. So mo na ni siya dinhi insert sa dye ang kaning angiogram is a series of x-rays nya, series of x-rays nga mahimo siyang video na makita ka in real time. Kita ang doctor in real time asa ang bleeding. Mo sa dugo, mix sa dugo man makita ka asa ni flow ang bleed. Once maki-identified, ilan na silang ayuhon nito. Ayuhon na dito ang source of bleeding. Radionuclide scanning is a non-invasive diagnostic tool by injecting a small amount of radioactive substance, and scans are completed and that locate the bleeding. Important kaayo for using radioactive materials, injections or dye to ask the patient for any allergies, no? Na importante kina siya. CBC should be taken. Tanawon ang sa importante hemoglobin. Mo tan-awon kay ngano man magdugo ang pasyente, maubos imuhang hemoglobin. Mo na nga magkuan ka maubos ang hemoglobin, mo na magkuan ka blood transfusion. Liver function test kay basin na doubt imong liver causing you to bleed. ABG and gastric or stool aspirate for Guaiac test. So Guaiac test is a chemical that turns blue in the presence of blood. Okay, these are tests used for patients with GI bleeding. Coagulation studies, platelets, and WBCs can be initially elevated post-GI bleed. Elevated creatinine levels indicating a slowing of the GFR, the glomerular filtration rate, and a decrease in the functioning of the renal nephrons. Lactic acid is elevated in these patients with massive hemorrhage. Okay, I'm gonna report to the doctor immediately. Complications. Hemorrhagic shock, tones of bleeding, perforation, nabuslot may cause peptic ulcer disease, neoplasm, varices, and inflammatory bowel disease. Abdomen becomes rigid and board-like. Peritonitis can leak na ang tae sa surrounding areas, no? Because of perforation. Nausea, vomiting, fever, tachycardia, hypotension, paralytic ileus, tinamumove mo na. Iniganat mo sa ascoltit mo, wala na sound, kay Na-paralyze na ang small intestine, yung intestine, and fluid and electrolyte imbalance. And there will be obstructions, and hypovolemia and hemorrhagic shock is imminent. Complication associated with massive GI bleeding. Nursing interventions for patients with gastric bleeding. Ask for patient history. Ask if the patient is taking medications that could be that could cause the bleeding. Ask if do you have any previous history of GI disease or surgery or any ulcers. Gabi, assess ko sa pasyente, masakit akong tiyan, o suka ko, or masakit akong tiyan kung mukaon ko, no? Klaro kaayo, no? Ulcer, no? Do you have any known bleeding or coagulation problems? What type of medications are you currently taking? No, like garlic can cause bleeding, feverfew, Chinese fungus, ganodermal lucidum, and ginkgo biloba. These are medications that you don't want to take if you have bleeding problems. Do you drink alcohol? Alcohol can cause bleeding. So ask them how often. Physical examination, a complete abdo assessment, inspection, palpation, auscultation, and palpation last. Inspection, percussion, auscultation, and percussion. No palpation, IPAP. Inspection, look for spider nevi, petechiae. Spider nevi, kanang mura og kanang cobwebs nga pink, murag ugat ba? Tiyan. Bruising in the presence of a palpable nodular liver indicates cirrhosis sa liver. Auscultation, hyperactive bowel sounds, or nothing at all. Palpation, rigid, board-like, tender abdomen indicating cirrhosis. First line and initial treatment for patients with GI bleeding. Provide oxygen. Ensure IV access. Naka sa ER, pasyente first gid na tagadan ni mo IV. It is in Canada, it is a entry to practice nga maka-insert kag IV. So, okay, ibaw na ka. So, sa Philippines, kay mag-training madali wala na training. Expected na ka nga maka-insert kag IV. Administer fluids and blood. Insert NG tube. Insert nyo sa NG tube. Unsaon pag-insert, I think ako na ninggi kuha ninyo sa una. Ako nang gitudlo ninyo sa una. Measure from the tip of the nose. Kuha ninyo imong NG, no? Tip of the nose to the tip of the earlobe. Nya, dinhi sa kuan. Kalimot ko nga part. Dinhi napita. Nya, timan ani mong number. Mao na number nga insert nimo diha ka photo. Okay? And then perform a portable x-ray. Insert lagi nimo gawas ang dugo sa kuan. And that will decompress their stomach, causing the alleviation of pain. Mawala gid ng pain. Consider possible gastric lavage. Prepare for endoscopy. Insert folate to evaluate renal perfusion and urine output. ECG, assessed for myocardial ischemia. Massive volume replacement is required. The replacement product should be warm to prevent hypothermia. Proton pump inhibitors to suppress acid secretions like pantoprazole. First nila na wato tagaan ng 80 milligrams nga bolus nga pantoprazole and tagaan og 20 milligram per hour. 4 milligram ba to? 20 ml per hour. Yeah, 4 milligrams, 20 ml per hour. Antacids are used to neutralize stomach acid, magnesium hydrochloride, milk of magnesia, aluminum hydroxide, amphogel, calcium carbonate tums, and sodium bicarbonate. Magnesium and aluminum hydroxide are commonly used. Patient with H. pylori can be given antibiotics like clarithromycin, tetracycline, amoxicillin, and metronidazole flagyl. Flagyl is the most common one used for patients with GI bleed. Assess for complications associated with GI bleeding with specific hemodynamic status. Assess patency of the NG tube to ensure the compression. Sometimes ipabutan sa doktor sa suction, intermittent suction of the upper GI tract and prevent vomiting. Ganong prevent na itong vomiting because pwede mo adto ang vomit sa imuhang lungs. NPO, gastric and enteral feeding should be discontinued until the source of bleeding is identified. Comfort measures include both pharmacologic measures. Head of bed should be elevated to prevent aspiration if vomiting. When medical management cannot stop GI bleeding, surgical intervention is indicated. Patients and family must receive education throughout the course of an episode of a GI bleed so they understand. If being transferred to ICU, explain to the patient about the transfer and get oriented with the ICU environment, equipment, and procedures. Ang first question sa pasyente, mamatay na ko, dili pa. No? That should be geared towards treatment of the disease. Knowledge transfer, number 10. True or false, antibiotic combinations are used to treat the inflammation caused by Helicobacter pylori. True or false, A or B? So we are in the last content of our discussion for this week. Nakuno kay mura kog EBS-CBN nga paminti ko mapadumok ko am guni siyang gamit na camera kanang ako ang DSLR ba niya is designed for video but inan akong gamiton kay way gamit care of clients with genitourinary emergencies. So the first one that we'll be talking about is acute kidney injury. So this is an abrupt, usually reversible decline in GFR. Cause of pre-renal. So we have different types of causes. No? Pre-renal includes syndromes that decrease blood flow through the kidney and therefore alter its disability to function, such as hypovolemia, decreased cardiac output, decreased peripheral vascular resistance, or obstructions of the renal vascular system. So intrarenal complication cause damage to the kidney tubules and includes nephrotoxic agents or diseases damage in the vascular or intestinal tissue, hypertension, diabetes, lupus, and infectious processes. Last one is post-renal causes result in obstruction. These are not types, they are causes. The pre-renal, intrarenal, and post-renal causes. Post-renal causes results in obstruction of the urinary tract, such as through calculi, renal calculi, prostatic hypertrophy, tumors, strictures, or neurologic causes affecting emptying of the urinary system. So the emergency department prioritizes identification and treatment of the cause and presenting complications and removal of any active insults to the kidney. The most common cause of AKIs is tubular necrosis, nephrotoxin exposure. Signs and symptoms: short-term weight gain loss, nausea and vomiting, hematemesis, melena, dysrhythmias, dyspnea, stupor, or coma. Mo yung mga signs and symptoms. So hyperkalemia, hyponatremia, hypocalcemia, hyperphosphatemia, and volume depletion or overload are the most common fluid and electrolyte imbalances resulting from loss of kidney's ability to excrete potassium and phosphorus, conserve sodium, and eliminate excess volume. In renal failure, calcium levels decrease because of the rise of phosphorus and the inability of the kidney to convert vitamin D to its active form, which facilitates calcium absorption from the guts. Treatment. So if AKI patients is non-oliguric, meaning to say that their kidneys are functioning well, their urine output is greater than 30 per hour, large volumes of fluid can be lost for this patient, so the patient may be dehydrated and hypotensive. So volume replacement with normal saline is recommended for this patient, and 1 to 3 liters initially at 75 to 100 ml per hour or more unless contraindicated by comorbidities, like right-sided heart failure, and is guided by outcomes goals such as urine output and tissue oxygenation, jugular vein distension, seen during auscultation, and vital signs. If AKI presents with oliguria, the patient may be volume overload. Oliguria is the condition where the urine output is less than 20. The patient may be volume overloaded and hypertensive. Is increase in volume is increase in blood pressure. So minimal fluids is given until the volume can be removed by diuretics or through the hemodialysis. Metabolic acidosis occurs because renal cells can no longer regulate, that's cells in the bills, can regulate concentration of hydrogen ions. Intravenous sodium bicarbonate may be used unless contraindicated by volume status. Indication for emergency dialysis. So emergency dialysis requires vascular access, usually a temporary femoral subclavian dual lumen. Dili na nila insert, no? Or here, there's a chest. This is an artificial kidney to act as an semi-permeable membrane. Gahapon naglimpyo ko kuan dialysis tube here. Filipino, no? Yeah. Yang gusto siya muli sa Pilipinas. Ning ko nga ayo pag uli kay mahal kaayo ang hemodialysis sa Philippines. Not na government pero kuan akong tiyo gani, no? Low kaayo. Stupor or coma, automatic na siya. Emergency dialysis. Volume overload and pulmonary edema, non-responsive to the aortic therapy. Emergency dialysis. Dangerous hyperkalemia and acidosis, unresponsive to medical emergency. Dialysis na siya. Una, importante kayo mong kidney class. Mangihi ka, inom ka tubig everyday. 6 to 8 glasses of water everyday. Importante kayo na siya. Hindi ka magka-acute kidney failure or injury. Knowledge transfer number 11. Below are indications of emergency dialysis except A. Stupor or coma. B. Volume overload and pulmonary edema non-responsive to the aortic therapy. C. Dangerous hyperkalemia and acidosis unresponsive to medical therapy. And D. FEVA. Diagnostic test for AKI. So initially stabilized but not pasyente, no? History and diagnostic testing focus on identifying the cause of your AKI. There's a lot of causes of AKI. Could be other diseases or like blockage. We do blood chemistry values. Okay, hibaw mo tanong phosphorus, calcium levels, potassium, sodium, urine analysis with sodium and potassium concentration, chest X-ray, renal ultrasound, and Doppler studies. CT scans will be ordered. Next is UTI. So UTI or urinary tract infection. Plus women are predisposed to having UTI than men. Kay taas man taog ko urethra, no? Classified as upper and lower, complicated and uncomplicated. Okay, so lower classification include the bladder and the urethra. Upper includes the kidney and the ureter. Uncomplicated, likely to improve with treatment. Complicated have risk from the name, have increased risk of failure with treatment due to comorbidities like your diabetes, history of UTI, pregnancy, anatomical abnormalities, including but not limited to vasocurolateral reflux, enlarged prostate or calculi, urinary tract instrumentation, catheter or stent, and infection associated with hospital or nursing home. So, kung nami pasyente nga tiguang niya send na sa emergency department niya confused gani ang pasyente, automatic din na will send urine sample because patients with UTI and older will have confusion. Cause is sometimes it's caused by bacteria residing in the perineum and the GU tract. Staphylococcus, Streptococcus, Escherichia coli, other coliforms. No, these are the bacteria. So, kung babae, dali kayo na siya masud, no? Na, man anak nimo. UTI of all types are common in women, likely associated with E. coli. Okay. Na mauna siya. So, kasagaran cause nila mga bacteria. Okay, that resides in our skin. Symptoms: lower UTI, bladder and urethra, irritability such as frequency, dysuria, urgency, microscopic hematuria, suprapubic discomfort, and cloudy urine. So upper UTI, pyelonephritis, ang tawag niya, other name, dull flank pain, no, with or without costovertebral angle tenderness, with pyuria, gross hematuria, naidugo ang ihi, malodorous urine, like baho, funny smell, chills and fever, leukocytosis, nausea and vomiting. UTI in children. So uncommon, but should be considered when there is irritability, decrease in appetite, and fever, and should be triaged emergently because sepsis in infants may be present. Diagnostic studies. So what you're seeing right now is a cystogram. So in cystogram, we'll see this is used for severe cases. Yeah, hindi makitaan kung nabay blockage, nabay tumor. Okay, so we always send, all the time, to confirm UTI. We send urinalysis and urine culture for uncomplicated lower UTI. Urinalysis will be positive for leukocyte, esterase, and positive for hematuria, WBC, and trace protein. So that it suggests nga UTI din niya siya. CBC with differential glucose and electrolytes, BUN, creatinine in prostate studies, lumbar puncture in infants, and blood cultures. KUB, or the kidney, ureter, and bladder x-rays, or ultrasound may be ordered and show a hazy outline of the kidney secondary to edema. And so what I mentioned is the cystogram. So your analysis and culture should be performed in a clean catch. Okay, clean catch. Hindi nila i-touch ang sudlanan kaya usin ma-infected, cross-contaminated. Treatment: antibiotics over 3-day or 2 weeks period, depending on upper or lower complicated or uncomplicated cases. Most commonly used medications for antibiotics for UTI are ciprofloxacin, fluoroquinolones, trimethoprim, and the best practice is to administer the first dose in ED before discharge or admission. Ciprofloxacin is what we always give, okay? And it depends on the local antibiogram studies or bacteria susceptibility. So sa among practice, tagaan na mo ciprofloxacin. It's either 1 gram or 2 gram, depende sa doktor, before the result of urine samples, Nya ini result na sa urine samples, ito na makita ang result sa urine culture, makita mo dito what type of bacteria o unsay mga tambal nga ngayon ihatag na niya. So ciprofloxacin almost covers all kanang causes of almost covers or kills all of the bacteria that causes UTI. So man ipadayon na ng cipro, Pero after ana magawa sa dayon, so ihatag taga sa doctor most specific antibiotics. Okay? So what you're seeing right now is a two-step urine. So this is what we use in our hospital to decrease the process of urine culture. Okay, ma-overwhelm ng hospital. So on ako ang kuan ha. Yon to laser pointer nako. So this is your container for urine collection. Kani dinhi na yellow ayon hikapa kay na siya needle diha ma-cause na siya injury. Instruct your patient, So you ask your patient, "Hi, can I have a urine sample, please? If you want to go to the washroom, and put it in this container and don't touch the inside, okay? Clean catch midstream urine, okay?" And then later on, when the patient brings the sample to you, kani siya din hinan siya purpose, okay? Storya na later. So mo siya entire set sa two-step urine. Now, first thing that you should do is to print the labels, okay, for the specific patient, and then remove the yellow sticker. Don't poke it, because if you poke it, it can cause injury. So wear your gloves, remove it, and then insert the first one will be the culture. The gray top is culture. The yellow top is the urinalysis. Okay, so unahon yung culture in order to prevent the likelihood of contamination. So imuha da yung ibutang ang imuhang yellow ang urinalysis. So the rest ilabay sa biohazard. Why do we use this? This is to protect the nurses from overspilling. To agsik sa to ang uniform ang ihi. Now, ang i-process ani sa laboratory ang kanilang yellow. Okay? One, not unless otherwise culture is ordered, kanilang yellow. If the yellow is suggestive of infection, magawas na itong mga leukocytes, WBC, protein. So, we inform nato, then doctor will say add up culture. Now, urine culture is obtained in the vacutainer. This is the vacutainer, okay? With preservative and laboratory will hold the gray top for about 24 hours, up to 24 hours, just in case doctor will order a culture for this patient. So urine cultures are only ordered if urinalysis is indicative of UTI, like what I said. If urine culture is required, the patient does not have to provide a new specimen. Kina naman ta, no? Nag-send naman ta. Safer for nursing, a specimen does not have to be opened. Poured, so pour na to yung agsik allocated into different containers at the bedside. Knowledge check. The nurse is about to give an initial dose of ciprofloxacin, 1 gram IV to a patient suspected of UTI. Before giving the drug, what should the nurse check first? A, if the patient has fever. B, if blood samples for CBC is sent to lab. C, if urine sample or urine culture was sent to lab. D, perform a skin test prior to administration. Next one is urinary retention. Urinary retention is the total inability to pass urine via micturition. It is a medical emergency. Urinary retention is caused by two different dysfunctions of the urinary system. Bladder outlet obstruction leads to urinary retention when blockage prevents the bladder evacuation of its contents. Despite a detrusor contraction, a common cause of obstruction in men is an enlarged prostate. Okay, deficient detrusor contraction strength results when the detrusor muscle no longer has the strength to contract with enough force or for long enough to complete emptying the bladder. Diagnostic test for acute urinary retention is focused on history, focus history, physical assessment, and a bladder lug or voiding record. And also you do urinalysis and a post-void residual volume bladder scan. So I haven't seen this in the Philippines, but I think we have it now. What you do is to have the patient void, and after voiding, I'm gonna turn on my laser light. After voiding, this is what you call the bladder scan. You have to bladder scan the patient. These are the batteries. This can be placed anywhere. Gibutang, I don't know ang gibutang nila diha. And this one is where you put your what do you call this? Gel. Okay. And this one is the probe, and this is the monitor, no? So dinhi kaning button dinhi nani siya modes for kids, males and females. So you have to choose the modes appropriately. And then once na imo na pick sukuan na set up na nimo, simple ra kay siya. It uses ultrasound. Nurses can do it. Butangan nimo og kuan gel sa suprapubic areas or the lower abdominal area where the bladder is, and then imo ni siyang have in contact with that area. Press na siya, trigger mo siya gun. Trigger nimo, makita nimo dinhi color orange or yellow kung pila ka percentage or pila ka ml ang retain sa pasyente. So usually for retention, urine retention, more than like 600 or 400, more than 400, mag-kuan na ta, mag kanang 600, yeah, 400, mag fully catheter or mag straight cath na ta, no? Urodynamics testing, ultrasound, mga diagnostic tests. So collaborative care, scheduled toileting and double voiding, intermittent catheterization may be required. An indwelling catheter is used when urethral obstruction renders intermittent catheterization uncomfortable or unfeasible, or when a patient is unwilling or unable to perform intermittent catheterization. No? Mas ingon ang uban, ingon ang libro nga mas nindot ang straight cath than indwelling kay Ang indwelling man gud maka-cause introduction of infection. For patients with obstruction at the level of the bladder neck, alpha adrenergic blocker to relax is given to relax the smooth muscle of the bladder neck and the prostatic area, and possibly dually innervated rhabdosphincter, diminishing urethral resistance. Surgical interventions are useful in managing retention caused by obstruction. So transurethral or open surgical techniques are used to treat benign or malignant prostatic enlargement, bladder neck constricture, urethral strictures, or dyssynergia of the bladder neck. Surgery plays little role in the management of urinary retention caused by deficient detrusor contraction strength. True or false? Surgery plays a little role in the management of urinary retention caused by UTI. That's knowledge check number 13. Nursing management. The nurse should insert a catheter unless otherwise directed by the doctor. So, patients with acute urinary retention should be taught strategies to minimize risk, including avoiding intake of large volumes of fluids over a brief period of time. Mao na nga magka-retention sila. No? Patients should be supervised to drink small amounts of water throughout the day. Patients are advised to warm up before attempting urination when chilled, and to avoid volumes of alcohol intake because it leads to polyuria. Hit or iced tea, and a diminished awareness of the need to urinate until the bladder is fully distended. And once your bladder is fully distended and you cannot urinate, oh my God, masyagit ka. Kasi hindi na gahapon ni syagit. Pag human akong catheter, you saved my life. No? Pero rude kayo. As a nurse, sometimes yung mga patient mga rude. As in, na I don't wanna point a specific race or a specific people, community, na agad rude kaayo, no? Tanaw nila nato nga kuan. Tanaw nila nato nga wantong yaya, no? Patients who are unable to urinate are advised to drink a cup of coffee or brewed tea containing caffeine to create or maximize urinary urgency, and to take warm showers and attempt to urinate while in the bathtub or shower. If none of these things work, go to the emergency department immediately. Testicular torsion. Testicular torsion is the sudden twisting of the spermatic cord, usually internally. Kina the spermatic cord na sa gawas, so may spermatic cord na sa gawas. Some sa ni mga libro, obvious kay, but stating the obvious. Causes vascular compromise of the testes within 4 to 6 hours and can lead to infarction with resultant atrophy and loss of spermiogenesis. So, testicular torsion occurs at the beginning of adolescence. 50% occur during sleep and are associated with congenital abnormality of the tunica vaginalis, the canal from which the testes descend. So, most of our patients, when they come, importante ka na sa nasugod ilahang testicular pain, ingon sila nga pagmata nila kay sakit, can be associated to trauma to the testes with significant swelling and sudden rapid movement and after they exercise. Wana mas object ka og supporter, sige exercise, sige twist imong kuan diha. So muna magka testicular torsion. Clinical manifestation of testicular torsion is an upwardly retracted testis with redness and edema at the site of the torsion, abdominal pain, nausea, and vomiting. These are morning imuhang testicular torsion mo ni sinitabo sa imong testicular torsion. This is a normal anatomy imuhang ang imong spermatic duct here, testis here, epididymis here. So because of exercise, sudden movement, unsa pa diha, no, nagtwist ang imong spermatic ducts. Okay, causing pain and swelling. And the pain is, kita mo yung expression sa now, sobra pa na, relax sila. Assessment diagnosis, Pren's sign. So to assess Pren's sign, the scrotum is gently elevated of the symphysis, no animo. So testicular torsion, the pain will increase. Hilap hindi. Kung epididymitis na siya, kay decrease in pain natin. Nakahinomdom ba kung itulong nga epididymis? Katura kung mag-inflammation to siya, wala epididymitis. Kung imong i-raise ang iyahang koan testis, anak ni mo niya, scrotum, kung magta ang pain, epididymitis na. Different in ilang treatment. Not always available and not always reliable, but a definitive diagnosis. A Doppler ultrasonography is another diagnostic test showing decrease or absence of vascular flow. Management, providing pain management, facilitating diagnostic and surgical interventions, providing education about the plan of care, and reassurance of the patient kay anxious man ang patient. Treatment for what do you call this? Testicular torsion is a manual detorsion under local anesthesia or surgery that must be performed immediately to promote salvage of the testis. Okay, so your treatment, surgical detorsion, ideally should be done within 6 hours of symptom onsets. Knowledge check. A patient with testicular number 14, a patient with testicular torsion, ask the nurse if there is another treatment other than surgery. The nurse is correct when the nurse response is A. The treatment of testicular torsion is a minor surgery called surgical detorsion. B. The only treatment is the removal of the affected testis. C. We can give you pain medication so pain will be controlled. D. An external fixation of the affected part can be done without the need for surgery. A, B, D, C, or D. Last part of our lecture for this unit is renal colics. Renal colic is a type of pain you get when urinary stones block the part of your urinary tract. So urinary tract, kidneys, ureters, bladders, and urethra. These are the ones that is included in your urinary tract. Stones may appear anywhere in the urinary tract. Stones form when minerals like calcium and uric acid are stuck in that or accumulate in that area and forms crystals. Sizes varies from grains of sand to a golf ball. The greater the size, the greater the pressure it exerts, the greater the pain. When stone sizes becomes bigger, it stimulates a painful response. Signs and symptoms of renal colic is a severe pain in the side of the body, between the ribs and the hips or in the lower abdomen. Pain that radiates from the back to the groin, and you feel nauseous and you vomit, appears in waves that last for 20 to 16 minutes. Siya flank pain, no? Radiates to the back. Sakit siya. Kita nung pasyente nani. Others are painful urination, hematuria, pink or brown, cloudy and foul-smelling urine, small stones in the urine, urgency in urination, increased frequency in urination, fever. Mo ni ang mga signs and symptoms of renal colic. So renal colic is caused by what? Caused by a stone, no, a pain that might be caused by a stone. Okay. So small stones may not cause any symptoms. Larger one causes renal colic, renal pain, especially when they cause blockage to the ureter. Causes high oxalate protein, high protein diet. So kung kay high protein diet, kaya exercise ka ng gym, kaya inom ka protein, or meat eater ka, kinahanglan ka nga mag-increase of fluid intake 6 to 8 glasses per day. Family personal history of renal stones, dehydration, obesity, gastric bypass surgery, metabolic disorders like hyperparathyroidism and UTI are the causes of renal colic. Assessment, patient may appear restless. Renal colic pain is located in the corticovertebral angle, lateral to the sacroprenous muscle, and beneath the rib that radiates to the flank, groin, testis, and labia majora if you have one. Be aware of previous nephrectomy or any other cause of renal impairment, and be aware of signs and symptoms of infection like for UTI. In UTI, wala man tayo costovertebral angle pain. Yan siya na. Okay, so red flags, fever, or so. What does it mean? Sorry, this conditions require immediate referral to the emergency department right away without without testing. Okay, so red flags, fever, or other signs of infection because of the signs of septic shock. Suspected bilateral obstruction stone, known critically ill, significant renal impairment patient, the hemodialysis patient, only one kidney is functioning, and a pregnant woman. So automatic direct to ER. Knowledge transfer. The following requires immediate referral to the emergency department if they show signs and symptoms of renal colic, except A, cough, B, non-critically ill patient with renal impairment, and C, only one kidney, and D, pregnancy. Management. So lab tests, serum creatinine and CBC, non-contrast CT scan to show kidney stones and other urinary organs, extracorporeal shock wave lithotripsy uses shock waves targeted to the kidneys and that breaks the renal calculi into tiny pieces and pass the calculi in the urine. Gaani mo sila filter aron ihi nila ang urine, no? Extracorporeal shock wave lithotripsy is done in the operating room. Ureteroscopy, so NPO prior to the procedure. Ureteroscopy is the insertion of a thin light scope through the urethra towards the bladder to remove the calculi. Percutaneous nephrolithotomy uses small instruments via small incision in your back to remove the calculi. Sedation is required during the procedure. Short-term treatment for this patient is to control pain, NSAIDs, ibuprofen, drugs to prevent muscle spasm, Buscopan, opioid medications. Prevention, drink 8 to 10 glasses of water, cut on sodas that contain phosphoric acid, low salt diet, limit animal protein, and reduce food that are high in oxalate like spinach, nuts, and rhubarb. Minimum. Nakikauban nga nurse na sigaw og spinach thinking that it's healthy, but it was not. So you should blend everyday into spinach. Nag-high in oxalate na ng pasyente, akong amiga. So nagkakuan siya, renal colic, renal calculi siya, and it needs surgery, and it will make your life different. So be careful, okay? And I think that's the end of our lecture for this week, Unit 6. And if you have any other question, please send me a message in our in WhatsApp or email me And these are my references for this week. Thank you very much for watching this video, and please do transfer your answers for the knowledge check in the stream, and let's see each other in week. This is what, week 14, 15, in our last week. Okay, thank you and have a wonderful day.